This lecture will cover the pharmacotherapy of erectile dysfunction. Erectile dysfunction is the inability to achieve or maintain an erection sufficient enough to have sexual intercourse. At the end of this lecture, you should be able to list medications associated with the development of erectile dysfunction, describe management strategies to control factors and medications associated with ED, describe different treatment options for ED, and evaluate drug therapy considerations such as drug interactions, pharmacokinetics, dose reductions, and the management of ED. What risk factors are associated with erectile dysfunction? Cardiovascular include hypertension, hyperlipidemia, diabetes, coronary artery disease, and peripheral vascular disease. Both kidney and liver dysfunction is associated with erectile dysfunction. Lifestyle factors such as age, smoking, obesity, and there's some question as to whether consuming alcohol and bicycle riding is associated with the development of erectile dysfunction. Trauma, surgeries, and medications can also contribute as well. So what medications are associated with the development of erectile dysfunction? Medications can cause about 25% of erectile dysfunction cases. So when you have a patient who presents with this, you may want to think about what medications may be contributing. Can I decrease the dose or discontinue a medication and hopefully see improvement in erectile function? All of these are dose related. Decreasing the dose may help, but in some cases you may need to discontinue the agent and try an alternate agent. So antihypertensives can cause erectile dysfunction because of their change on the vascular tone. The biggest problems are non-selective beta blockers, calcium channel blockers, and clonidine. Patients who have problems with this, ACE inhibitors and ARBs, angiotensin receptor blockers, are the preferred agents. Antidepressants can increase serotonin and decrease dopamine activity. They're also associated with delayed ejaculation and a decrease in libido. The biggest problems are the SSRIs and the tricyclic antidepressants. Bupropion is associated with less erectile dysfunction than others. Antipsychotics block dopamine and increase prolactin levels. Anticonvulsants will induce CYP3A4 mediated androgen metabolism and also decrease DHEA. 5-alpha reductase inhibitors can decrease levels and inhibit action of dihydrotestosterone. And opioids. This is a very well-known and studied adverse reaction of opioids, but it's not really talked about very much. Opioids can decrease our testosterone level. Tramadol may have less of an association with erectile. Correct answer here is all of the above. All of these agents have the potential to cause erectile dysfunction. So how do we treat erectile dysfunction? What options are available? We have pharmacologic and non-pharmacologic therapies. From a pharmacologic perspective, our workhorses are really the phosphodiesterase inhibitors such as sildenafil, vardenafil, tadalafil, and avanafil. We also have prostadil, papaverine, and phentolamine that can be used, but there's some problems associated with those medications. And then testosterone is an option in patients who have low testosterone levels. With anything, it's also recommended to counsel patients on non-pharmacologic strategies such as lifestyle modifications, psychotherapy, medical devices like vacuum erection devices, or even surgery. Kind of a good rule of thumb here is to think about what's reversible. Before we add on drug therapy, what can we either treat or reverse? So if the patient has low testosterone, replacing their testosterone level is a reasonable place to start. Is it possible that their erectile dysfunction is psychogenic? Maybe psychotherapy would be a better first line for that patient. Do they have other risk factors? Do they have hypertension or diabetes? Can we adjust all of those other underlying disease states or optimize medication therapy for those underlying disease states and potentially see a little bit better or an improvement in their erectile dysfunction? Are they on medications that are thought to be contributing? Can we change or decrease doses of those medications? Good next option, once we've kind of addressed the reversible items, next next option would be to recommend lifestyle modifications. So can we recommend smoking cessation or weight loss in our patients? After we've done those things, the phosphodiesterase inhibitors are going to be our mainstay of therapy. Phosphodiesterase inhibitors inhibit the conversion of cyclic GMP into 5' GMP. So this is going to allow there to be more cyclic GMP around. This is going to decrease our calcium into cells, which is going to cause smooth muscle relaxation and penile erection. Looking at this flow chart, we need to recognize that sexual arousal is at the top of this. In order for these drugs to work, patients need sexual stimulation. They're not going to do anything on their own. They do still need sexual stimulation with these. They are considered to be facilitators, not initiators. These are relatively non-invasive. They're easy to use. They're effective. They're well tolerated. These are the preferred agents for erectile dysfunction. Originally, sildenafil was studied as an anti-anginal, antihypertensive medication. However, it was found to have an interesting side effect. Other than improvement in erectile dysfunction, these drugs can cause. So let's look at these from a pharmacodynamic perspective. So the corpus cavernosum is where we want these drugs to work. This is the erectile tissue. I want to kind of orient you to this chart for a minute. So all of these numbers tell us where in our body, what isoenzyme are these drugs working on. The smaller number means that it's more likely to act in that location. The bigger number means that it's less likely to act there. So let's take sildenafil for a minute. So if we look at isoenzyme number 6, sildenafil has a number 7 here, yet it has a number 1 in the corpus cavernosum. So it is more likely to act on the corpus cavernosum than it is on the retina, causing those visual disturbances. If we compare all of our agents for visual disturbances, we have the smallest number in vardenafil. Vardenafil is more likely to cause visual disturbances than any of the other agents because of its selectivity at that specific isoenzyme. So let's look at some of the specifics for sildenafil. Brand name for this one is Viagra. Sildenafil is also available as Revatio, which is available generically for pulmonary hypertension. Although it's marketed under the brand name Revatio, generically sildenafil, it does have different doses than what Viagra does. Viagra itself is not available generically, but the generic Revatio in similar doses can be used in our patients who have insurance issues. If they don't have insurance, or it may be a preferred agent on their formulary, to use a different dose than what's recommended by Viagra using the generic formulation. Going off of the Viagra dosing, Viagra is available as 25 to 100 milligrams. The typical starting dose is around 50 milligrams. Revatio, the generic sildenafil, is available as 20 milligram tablets. So a reasonable place to start would be 40 milligrams with that generic product. It does need to be dose adjusted in renal impairment, hepatic impairment, older adults, and patients who are on 3A4 inhibitors and alpha blockers. Our max concentration is decreased by about 30%, and we do have a max or a time to max that's also delayed when this product is taken with food, specifically a high fatty meal. So it's best to take this on an empty stomach. We have optimal concentrations achieved and at a faster time. We will get to those max concentrations. It is metabolized through the liver in CYP3A4. Onset of action is about 30 minutes. However, we do recommend that patients take these about an hour prior to sexual activity, just to be on the safe side, to make sure that they've given it enough time to really work. Vardenafil, or Levitra, is available as an orally dissolving tablet in addition to just the tablets that one would swallow. Does need to be dose reduced for hepatic impairment or if patients are on concomitant 3A4 inhibitors or alpha blockers. Again, we have a decrease in Cmax and Tmax, especially with a high-fat meal. Onset of action is, again, about 30 minutes. And a similar half-life to sildenafil. Both of them have a half-life of around 4 hours. Tadalafil, or Cialis, can be dosed as needed at a dose between 5 and 20 milligrams, just as needed prior to the onset of sexual activity. It also can be dosed in a lower dose, 2.5 milligrams once a day, on a daily basis to help with erectile dysfunction. There are dose adjustments for renal impairment, hepatic impairment, and concomitant 3A4 inhibitors or alpha blockers. There is no effect of food on tadalafil. Also metabolized through 3A4. Its onset of action is very similar, about 30 to 45 minutes. However, it does have a longer half-life. You may have heard tadalafil or Cialis referred to as the weekender. Because of its long half-life, patients can take this and will have coverage for the whole weekend. Avanafil is the newest agent, and this one is really a Me Too drug. It is very similar to all of the other agents. It potentially has a little bit faster onset of action, about 15 to 30 minutes as opposed to the 30 minutes for the other agents, so patients can take this one about 45 minutes before sexual activity. That really is the only benefit or difference that this product has over some of the other products. You may be wondering about the phosphodiesterase inhibitors and their role in women. Sexual dysfunction in women may be the result of lack of blood flow to sexual organs. These will help to increase blood flow, but studies have shown no overall therapeutic effect, so these are not recommended for females with sexual dysfunction. Renal dose adjustments are listed. For patients who are taking sildenafil for pulmonary hypertension, there are different dose recommendations and different dose adjustments for patients with renal dysfunction. Drug interactions. All of these drugs will interact with nitrates, alpha blockers, cytochrome P450-3A4 inhibitors, and vardenafil will interact with antiarrhythmic agents. With nitrates, these can cause profound hypotension because of an increase in nitric oxide. All of these, except for tadalafil, you need to wait until 24 hours after your last phosphodiesterase inhibitor dose to initiate a nitrate. Because tadalafil is so long-acting, you need to wait 48 hours after a tadalafil dose before initiating a nitrate. These patients should not be on concomitant scheduled or PRN nitrates. So even nitroglycerin, PRN chest pain would not be a good option for these patients. Alpha blockers can cause hypotension. CYP3A4 inhibitors, these drugs are metabolized through CYP3A4, so we want to avoid that combination. And then vardenafil has the potential to prolong the QT on its own, so you want to avoid that with patients who have underlying QT prolongation or who are on agents, who are on agents that can prolong the QT. Other agents for erectile dysfunction. All of these have some significant concerns that make them a little bit less appealing for the management of this disease state. Alprostadil is a prostaglandin E1 analog. It's available as an intracavernosal injection or a transurethral suppository. This needs to be done in the physician's office. It takes about 5 minutes to start working. It has a duration of action of about 30 minutes to an hour. It's injected into one side of the shaft and then the tissue is massaged to evenly distribute the drug. So knowing that it's a little bit more invasive, and because of its fast onset of action and its need to be done in the physician office, this one definitely has some limitations. Papaverine and phentolamine. These are non-FDA approved as intracavernosal injections, but they can be used. They're typically mixed together and then may or may not be combined with alprostadil as well. Similar concerns as to alprostadil alone. These are intracavernosal injections that need to be performed or administered in the physician's office. Testosterone is an option if patients have low testosterone levels. It can help with decreased libido, fatigue, muscle loss, sleep disturbances, and depressed mood. We do have a variety of administration options. It's available intramuscularly as buccal, topical, or sub-Q. A 3-month trial is recommended. Common adverse effects: gynecomastia, dyslipidemia, polycythemia, and acne. We also could have some dermatologic problems for the topical formulations as well. If the testosterone is normal, we don't want to use testosterone. You don't need to replace it in a normal testosterone. You may have also heard of yohimbine being used for erectile dysfunction. This is an over-the-counter herbal supplement. It's not FDA approved, and it really just doesn't work. There's pretty limited data, and it's been shown to be just as effective as placebo. So it's not recommended for the management of erectile dysfunction. So things to think about when you see a patient with erectile dysfunction: you want to think about pharmacologic and non-pharmacologic recommendations, pharmacokinetics of each of our phosphodiesterase inhibitors, including dosing schedule, dose adjustments, duration of action, and then the onset of action and effects of food, any drug interactions, and then how invasive is our therapy going to be. Let's look at a patient case. We have a 64-year-old male who comes to clinic for a follow-up appointment regarding a recent discharge from the hospital due to community-acquired pneumonia. He reports that his breathing has much improved, but he complains of not being able to have sex with his wife anymore. Past medical history of hypertension, diabetes, high cholesterol, depression, and a recent diagnosis of community-acquired pneumonia. Height and weight are listed. He looks to be a little on the overweight side. He does have an allergy to sulfa. He's a painter. He lives at home. He's married, has 1 daughter. He drinks 1 alcoholic beverage per day, does smoke 1 pack of cigarettes per day, no illicit drugs, and he is uninsured. He takes moxifloxacin, aspirin, lisinopril, hydrochlorothiazide, sertraline, simvastatin, metformin, glipizide, omega-3, and oxycodone. So what are some of his risk factors for erectile dysfunction? He does have diabetes, he has hypertension, he's got some medications which may contribute, such as oxycodone, hydrochlorothiazide, and sertraline. He's older, and he does take alcohol, so there's that questionable alcohol risk. He's diagnosed with erectile dysfunction. What additional information should you take into consideration when thinking about pharmacotherapy for this patient? So you want to think about some of your dosing considerations. What's his renal function? What's his liver function? Do we have a testosterone level on him? Should we start by supplementing some testosterone first? He is on moxifloxacin, which can prolong the QT interval. So you want to think about QT prolongation. And then he also has some lifestyle modifications that we could recommend. Weight loss, smoking. We could recommend that he avoid alcohol. Or once daily PRN, A, is the correct answer. Vardenafil would not be recommended because of the potential for QT prolongation with his moxifloxacin. Tadalafil, that dose is too high for daily dosing. 2.5 to 5 milligrams is the recommended dose for daily dosing. And then alprostadil is a little too invasive. It's not something that you would want to recommend first line. So sildenafil is a good option. This is the generic version of it, so the dose is a little bit different. However, this patient doesn't have insurance, so the generic is going to be a cost saving for him. So in summary, Erectile dysfunction is a common disease that primarily affects middle-aged men over the age of 40. There are several risk factors for erectile dysfunction, most of which are similar to cardiovascular risk factors. We have several pharmacologic and non-pharmacologic options, but phosphodiesterase inhibitors are the mainstay. Non-invasive therapies are our preferred first-line options, and our pharmacologic treatment needs to be tailored to the individual patient. Thank you.